The Diabetes Care Program of Nova Scotia developed a decision tool for healthcare providers to assist in determining who should test their blood sugars and for how long. This standardized approach to the issue and to the messages given by providers leads to improved quality of care. It also ensures that persons with diabetes and their individual considerations are kept front and center in all decisions. With a focused mandate on the development, dissemination, and monitoring of guidelines to improve diabetes care, the Diabetes Care Program has produced a number of resources, including guidelines for residents in long-term care, physical activity and exercise, insulin dose adjustment, and foot care. These resources can be found on the website. The need for a decision tool for self-monitoring of blood glucose was supported by compelling local evidence that demonstrated variations between and within provider groups around the recommended frequency of testing for different populations and the use of the monitoring results. It was also informed by a recent report by the Canadian Agency for Drugs and Technologies in Health, CADTH, that concluded that people with non-insulin-using type 2 diabetes may not need to test their blood sugars as often as they do, and in some cases may not need to test at all. Finally, there is also the concern for the growing costs of testing for both individuals and their families and the healthcare system as a whole. To keep the focus on persons with diabetes and what is ultimately best for this population, this video will explore the issues behind the need to focus our approach to testing, the reasons for the change, and the need for a decision tool to guide more consistent practice among providers.
For years and years, we were always telling patients that you had to check your blood sugars, and if you weren't checking your blood sugars, you were doing something wrong. And now we're individualizing that. So not all patients with type 2 diabetes need to check their blood sugars all the time, but it needs to be thought about carefully by their healthcare team when making recommendations. So I think that change in recommendations for a lot of patients is a potential for great confusion.
For many years, patients with diabetes have been advised to regularly measure their blood glucose, and they do that by poking their finger and putting it into a little machine and getting a value. And we've told them that part of their being a good patient with diabetes is to regularly monitor their blood glucose. So our definition of this for patients with diabetes was you're good if you measure your sugars regularly.
What exactly did your doctor mention to you? So I think that ultimately what it means for the patient is that if we can establish some consistent guidelines for patients in different areas, whether insulin dependent or non-insulin dependent, taking oral hypoglycemics or just diet controlled, then it should be a lot easier for the patient to get a handle on what they should be doing and be more comfortable with what's going on. Mixed messages are difficult for them.
I was testing every day until the last time I met with a nurse at the clinic, and she said, you don't have to. Once a week would be sufficient. But I do it twice a week, just to see what level I'm at and how I'm doing.
I think it's important to keep in mind that, that some people will be initially alarmed by these new recommendations. These would be people who have worked with their care providers to really incorporate the testing into their regimen. So they make good use out of the testing information that they get. So for instance, they would regularly test and then use the feedback from that testing to change their behavior. So some people might see if their sugars are a little high in the morning, then they'll alter their pattern of physical activity so that they can bring their blood sugars back into range.
Well, in my case, I think it would be unnecessary to do it now. When I first started, I used to do it daily, either when I got up in the morning or before I went to bed. I did the testing.
I mean, if we want to get the best bang for our buck, why are we focusing so much on testing? Does that really change the behavior of our patients? Apparently it does not, based on the evidence. So what we really want to do is focus more aggressively on those things we know make a difference. So regular exercise, appropriate diet, and the other factors that we as physicians look for, so cholesterol control, hypertension control. Those are the issues we need to focus on with our patients. And sometimes I think we focus so much on, are you measuring your blood glucose or not? We've forgotten that that's probably not the important issue. The important issue is, are you making the lifestyle changes that can help you be healthier over the long term?
There are other lifestyle interventions that we need to as well focus on, as not simply monitoring their sugar at home, but we certainly ensure that they're having their blood sugar monitored at the hospital through the laboratory. So we do A1C testing. And of course, we focus on blood pressure monitoring and activity goals. So there are multiple lifestyle interventions as well as monitoring, their blood sugar.
The big issue now is if we cannot foresee a benefit for patients who are not on therapy at all or who are on oral agents or medications only, if you're looking at the balance of risk versus benefit, what's the potential benefit to them? We really haven't found any potential risk, pain, cost, and the only bit of clinical evidence that we have that is that patients who are asked to measure their blood glucose frequently tend to be more anxious about their disease.
I think with the change, we need to be careful to consider who this will impact, because it not only will impact the patient, but also impact the care provider. And I think we need to be mindful of not throwing the baby out with the bathwater. That the message here isn't that, oh, you don't have to test, so forget about testing. That in fact what this does is it becomes a tool for us to use, and that's important because a tool really becomes a teachable moment. So the healthcare provider and the individual with diabetes can sit down and say, well, does testing make sense? How does it make sense? And what are the principles that I would need to become familiar with in order for it to make sense for me? So that speaks very clearly to what we call knowledge translation, which is where we take science-based knowledge and we turn it into practices so that the individual can benefit from that knowledge.
On a day-to-day basis, I obviously have a lot of interaction with diabetic patients. And during that interaction, I will ask a variety of questions that gives me some idea of how things are going. If I have a clearer understanding myself of what is expected of the patient, then it probably will be of benefit to me in trying to follow up with the patient to ensure that they're doing what they're doing, to have a better idea of how to answer the questions that I'm being asked by them. And if the pharmacist has access to the decision-making tool, then it gives them, or it should at least give them, some rough idea of what that patient should be doing.
How do you feel about me telling you that you don't have to take your sugars anymore at home?
Oh, yeah, that feels good because, as I say, my fingers will really be happy about that one.
Lovely.
This one in particular.
I still have to make sure, once again, that not all person's diabetes is the same. So I have to carefully examine the person who is sitting in front of me and make sure that I'm giving appropriate recommendations. But certainly I'm using this now new tool in evidence-based medicine to guide my recommendations.
When the COMPASS report, which was what started all of this from the Canadian Agency for Drugs and Therapeutics, a national agency, came up with this report. When I first read it, it was scandalous. This is not how we manage type 2 diabetes. But after spending a fair chunk of time going through it, and I was convinced, much like I think most others will be.
I mean, we're well aware on an everyday basis of the kinds of pressures that are being put on the healthcare system, because ultimately they filter down to us. And if this is one way that we can relieve a little bit of the pressure, then ultimately it's not only to the benefit of the patient, but I think it can be seen to the benefit of healthcare, I guess, coverage itself.
Strips are not inexpensive. So in Nova Scotia alone, we spend $8 million a year on strips. That's an astonishing feature. Just imagine what we could do with that money if we could somehow siphon that in to diabetes research, or for paying for other medications for our patients with diabetes that we know have benefit to their ultimate health. So we are putting a lot of money into something that has no benefit for people. So we really need to reconsider this and put our priorities in best suiting the patients and the health of our population.